Hi everyone, welcome to Women Empowerment Shadowing Session. Today we have Dr. Amanda with us, who'll be talking about the field of anesthesiology. Thank you, Dr. Amanda, for joining us today. Whenever you're ready, please begin your presentation.
Thank you guys so much for inviting me. I am Amanda Shih. I am an anesthesiologist and intensivist at Massachusetts General Hospital, which is in Boston, in Massachusetts. And today I wanted to share with you how I kind of got into anesthesiology, about the specialty itself, as well as give you an opportunity to get a glimpse of some of the things that I will do day to day, some of the different types of cases we are involved with, the different types of anesthesia, and then as well as talk about some of the issues that arise being a woman in anesthesiology. So in terms of a little background, so I'm originally from Metro Detroit in Michigan, so I'm Midwestern, but I am currently in Boston. I went a little bit of a different route than many people. I actually went to a liberal arts college called Bard College at Simon's Rock for 2 years, and then transferred into an engineering program, so a biomedical engineering program at the University of Michigan. I finished both my bachelor's and a master's in biomedical engineering, and I actually had a short time as a contract engineer before I started medical school. In medical school, I was part of the charter class, so the first ever class at a brand new medical school called Oakland University William Beaumont School of Medicine. This is also in Michigan, and I will say, I just want to put a plug out there that if any of you guys are looking to go to a brand new medical school and you're worried about it, I could say that, it's not all about where you go to medical school, it's also about what you do there. And so being part of a brand new medical school, felt scared about the possibility that I wouldn't be able to match or do the things that I wanted to do, but I was definitely successful in achieving my goals. To continue on, so I graduated from medical school in 2015 and matched in 2 separate places. So in the US system for anesthesiology, we can match into categorical and advanced programs. So that really means is for the advanced programs, it's separated. So internship is separate from the residency in a particular specialty. So in anesthesiology, I matched into an advanced program by choice. It was my top program, but there are other programs in which they're called categorical programs, and those ones are all combined. So the internship plus the residency are all in one place and they're at one program. So for me, I decided that I wanted to stay closer to home for another year. I also wanted to save money because I was very aware of the fact that Boston was extremely expensive to live in. And having lived in the Midwest most of my life, I was used to a certain cost of living, which was a huge culture shock, or a huge shock for me when I moved out to Boston. So I stayed for 1 year at Henry Ford Hospital in Detroit to do internship. And during internship as an anesthesiologist, what we typically look for, or what we typically do, is a wide variety of specialties. So in order to be a good anesthesiologist, you really need to know medicine. You need to know about how to diagnose people's chronic medical issues. You need to know how to manage their chronic medical issues. And so these are all really important fundamentals in being a good anesthesiologist. And that's why during my internship, I had 2 rotations in the ICU. I worked very closely in internal medicine. I did most of my year in internal medicine. And I also get exposure to cardiology and radiology and did a little research as well. So those are all kind of the foundational rotations and experiences that I did in order to then prepare me to become an anesthesiologist during residency. After a year in Detroit during internship, I then moved here to Boston to complete a 3-year residency in anesthesiology at Mass General. And I stayed for 1 extra year of training to do a critical care fellowship. So to jump into the meat of this question, what do anesthesiologists do? So to give you a definition that the internet says, at least, is that anesthesiologists evaluate, monitor, and supervise patient care before, during, and after surgery. We deliver anesthesia, we lead an anesthesia care team, and we are really focused on optimal patient safety. We think about our anesthesia care plan, pain management, and we can also participate in critical care medicine as well, which is one area that I do. So big picture, the question that comes up is, what do I do day to day? I ensure that patients can undergo surgery safely. And that kind of appears in a couple of different ways. And so anesthesiologists can be the person that's in the room with the patient the entire time through surgery. We can also work in a care team model, which means that I work with residents and CRNAs, or registered nurse anesthetists, certified registered nurse anesthetists, in order to provide anesthesia to our patients. When I'm working in a care team model, that means that I am not in the room the entire time. There is either a resident or a CRNA that is in the room the entire time with the patient, but I have looked at the patient both from their comorbid diseases, so if they have high blood pressure or hypertension, if they have had a heart attack, if they've had a stroke. These are all things that I have assessed and looked at. I look at them in the pre-op area, and as well as work with my team to determine what the safest way to provide anesthesia is. So that's one way of practicing. And another way, like I said, is if I were to care for the patient from the beginning, so before even going into surgery, through surgery, up until we drop off our patients in the recovery room. And so an anesthesiologist is essentially someone that can provide anesthesia, meaning that individual who undergoes surgery, that they can actually tolerate having surgery being done to them. And I say it that way instead of saying I put my patients to sleep, because it's more complicated than that. We're not just sending our patients off to sleep, and many surgeries can actually be done completely awake with the patient. So these are all things that I like to just bring up as a part of my job as an anesthesiologist. And we'll delve a little more into what that kind of looks like. Now, since we are focusing on the women empowerment component, I think it's important to talk about the gender breakdown within the field of anesthesiology. This is actually kind of older data. It is more male dominated. The data I pulled this from was from a few years ago, and it actually is like high 30% women. I just rounded up to about 40% to make it an even number. But what we have found in anesthesiology it is still male dominated. We have a lot of residency programs in which are mostly men or 100% men. And there are other programs that are more balanced, but currently the landscape is that there are more men than women practicing anesthesiology. I wanted to delve in a little bit about reviewing how to become an anesthesiologist. I've kind of alluded to this, but everyone needs to, at least in the US, you have to finish college or get some kind of undergraduate degree. You then have to get into and complete medical school. You complete a 1-year internship or combine it with your residency, and that's 4 years. And then all of our fellowships are 1 year long. So I wanted to also talk about our subspecialties or other fellowships that you can do in anesthesia, just because it's important to be able to understand the different pathways that exist within our field. So first and foremost, cardiothoracic anesthesiology, so patients that undergo open heart surgery or any kind of cardiac surgery. Frequently, a cardiac anesthesiologist is the one that will be providing that care. It's not required for all cardiac procedures, but a cardiothoracic anesthesiologist is someone who gets an extra year of training to be able to use things like a transesophageal echo. That is a special device that we can insert while patients are asleep in the esophagus to be able to monitor the heart throughout the entire procedure. So that's really important for our cardiac surgeons to be able to assess, whatever repair that they did. So for example, if someone has a heart attack and they need a coronary artery bypass surgery, what we will do is we will say, okay, before they get their bypass, this is how the heart is squeezing. And then after they get their bypass, we can assess again, okay, is the squeezing of the heart any better? Other things that happen under open heart surgery include changing out the valves. So if you think of the heart, there's multiple valves that prevent backflow of blood, so that allow for blood to go out of the heart and into your entire body. And those valves sometimes get kind of leaky. And when they get leaky, they either need a replacement or a repair. And most frequently it's aortic stenosis that we see, or the aortic valve gets narrower. And in those types of procedures, after the valve goes in, the cardiac surgeon will rely on the cardiac anesthesiologist to assess, to say, hey, is the valve sewed in really well? Is it working nicely? Are there any other issues that have arose during that time? So that's an important type of anesthesiologist. I have done a critical care fellowship, so I am a critical care anesthesiologist. Many people are actually not aware of the fact that anesthesiologists can be intensivists or ICU doctors. I've been asked this in the past, what do you even do in the ICU? Do you just go there and intubate patients? Do you just go there and do lines for those patients? And that is not what I do. In fact, what I do in the ICU is that I am the main doctor in the ICU, diagnosing and rounding on patients, being able to treat patients, coming up with a treatment plan, and seeing that plan through. So if a patient is in the ICU and they ask for the attending doctor, that can be an anesthesiologist that has gotten specialized training in critical care medicine as well. So when I'm in the ICU, I am not in the operating room. I'm 100% in the ICU at that time as the doctor, but I also spend time in the operating room as well. People can also get additional training in neurosurgical anesthesiology, for patients that undergo, we say, craniotomies, craniectomies. That means that they go into the brain and either resect tumors or do any other kinds of complex procedures in the brain. Obstetric anesthesiology is another area in which we can specialize. So many of you guys may have encountered or heard encounters with anesthesiologists on the OB floors, because the anesthesiologist or the team are the ones that are placing epidurals or spinals to allow for C-sections or any other kinds of emergency procedures that need to happen with laboring moms or pregnant women. Pain medicine. So this is an interesting area too. Anesthesiologists are very comfortable with pain medication and understanding kind of the usage of different types of pain medication, because we use it so frequently in the operating room. As you can imagine, undergoing surgery can be a pretty painful thing, and as a result, we become comfortable with the use of different kinds of medications and adjuncts. When you specialize in pain medicine, though, there's two components in anesthesia. One is the acute pain medicine area. So that means that people who are in the hospital that have just had surgery, they have acute or very specific time frame of pain. Those are people that are specialized in being able to do special kinds of procedures called blocks. So that means that usually under ultrasound, we would identify nerves and place some local anesthetic, also known as basically numbing medicine, around the nerves in order to address someone's pain. So if someone has had surgery in their leg or their arm, we can find the nerves that actually innervate pain into that extremity, and we can numb them up, which really helps with pain. Chronic pain is a separate type of specialty in which they address patients out as an outpatient. So people who are not in the hospital, chronic pain takes care of a lot of the patients that are at home. Oftentimes it's chronic back pain, but it can also include patients that have cancer and chronic pain from cancer as well. Those types of physicians also can do procedures. So a more common procedure that a chronic pain specialist could do is something called a lumbar epidural steroid injection. So under X-ray or fluoroscopy, they'll go ahead in with a needle and put some steroid in the epidural space of the spine in order to address back pain. So that's a procedure that can be done by chronic pain medicine doctors. Now, pediatric anesthesiology, many of you guys, I'm sure, know that kids also sometimes need surgery. Little babies can need hernia repairs. There are other congenital things that babies are born with, or kids that get into trouble. So falling from the monkey bars and breaking an arm or extremity, those kiddos frequently need surgery as well. Another area where the pediatric anesthesiologists go that people don't frequently think about is a lot of kiddos need some kind of imaging. So if someone were to need an MRI as a kid, that it's really hard to ask a kiddo to lay completely flat and still inside of an MRI machine for sometimes over an hour. So sometimes those kiddos actually undergo anesthesia in order to get the image. So pediatric anesthesiologists get extra training in caring for tiny, tiny babies, kiddos, and so that they are ready and specialized to address some of the issues that come up with congenital diseases or any other kind of related to kids who have a very different physiologic status than adults. And finally, another fellowship people don't think about is that anesthesiologists can actually go into palliative care, where we focus on kind of end of life issues and things like that. Now, many of you guys came here to get an idea of what a day as an anesthesiologist looks like. So as part of this shadowing, what I'll say is that my day-to-day kind of looks like this. So when I break it down, as an attending, so that means I am done with training, I'm done with my residency and my fellowship, this is what my schedule looks like. When I was going through training, my schedule looked quite different from this. So I do want to just focus on that. My schedule as a resident was much busier than what I kind of put on here, but currently as an attending, my schedule is much better. And a piece of advice for you guys is, as you're going through your journey and you're trying to figure out, do I really want to do this specialty? Is this what I want to be doing? You need to really look at what the attending is doing, because the majority of your time is going to be as an attending. So while residency is a glimpse of, getting to learn and get an understanding of whatever specialty you decide to go into, frequently residency includes a lot of really long hours. 80-hour work weeks are a real thing. We do actually work that long when we are residents. We do take calls that, when I was an intern, I took a call that was 36 hours long. And that is something where I've spent 36 hours in a hospital straight. And that was training. That was 4 years of my life. And now the rest of my career will look more like this. So in the morning, my particular institution does it so that our cases, our surgeries start at 8 a.m. In a lot of other hospitals, surgeries actually start earlier than 8 a.m. But in my hospital, it starts at 8 a.m. So I get to the hospital about 7 a.m. I change into scrubs. And then at that point, I go and find where my patients are. Typically, my practice is in an anesthesia care team model. So I will have more than one room. Usually it's 2 rooms that I'm overseeing. So I want to go meet the patients. When I say do a pre-op assessment, so pre-operatively, I want to go look at the patients, ask them about, did they eat last night or this morning? If someone has eaten and it's an elective surgery, then they should not get surgery, because that can be dangerous when we send patients to sleep. If you've eaten something, that comes up from your stomach and sometimes can go into your lungs. And so things like that, I'll ask. Other things like finding out if someone has any new medical problems that maybe are not in the chart. Other things like, now that we are living in a pandemic, if someone has had a COVID test or if they're currently COVID positive, this influences the way that we set things up and also can influence our anesthetic plan. Other things too, the important things in anesthesia is to ensure that someone can safely undergo surgery. So someone who is heart might be very sick, may not be a safe person to undergo anesthesia. And as a result, that's why it's really important for us to assess these patients to determine, is there anything else I should do for the patient to make sure they can safely undergo anesthesia and surgery. After I've assessed all of that, additionally, the other really important thing that we do in our assessment when we see patients is determine their airway status. So many people may not realize this, but I think with the pandemic, more and more people have. A big component of what we do in the operating room is actually airway management. That means that after patients go to sleep, if they're getting general anesthesia, we would place some kind of breathing device in the mouth and to allow us to hook up a patient to a ventilator, either to have the patient breathing on their own or with help from a ventilator machine. And so those are things that it's important for us to determine. There are certain factors around the mouth or in the mouth that can make someone's airway or make their intubation much more challenging. And there are other things that help us realize or see that it could be easy in order to intubate them. So that's another area we really look at. So like I said, around 8 a.m., we do our first cases. If I'm when I put on there doing my own room, that means that I am the person that stays with the patient the entire time. I will go ahead and transport the patient into the room. We get all of our monitors on. We stay with the patient the entire time and then go from there. Usually I am supervising, so that means that I will run in and make sure that the patient goes to sleep safely. So that's called induction. So I will be there for that critical component of the anesthetic, and then make sure that their airway is safely secured before I go see another patient and do the same thing in another room. In anesthesia, it sounds crazy, but we do really need breaks. So if you are in the operating room caring for the patient at the bedside, you really can't leave, and it's very challenging in terms of your cognitive ability and even physical ability in some of the sicker patients that we care for, or in certain surgeries that require that have a lot of blood loss or other kinds of big changes in our hemodynamics or our vital signs. And so as a result, it's important that we build in breaks for our anesthesiologists and our CRNAs and residents. So that's why we have a morning break. We usually go out for a lunch break, and then we get an afternoon break. But during the break, in the way our country practices anesthesia, there must always be an anesthesia provider at the bedside with the patient undergoing surgery at any given moment. So that means that you can't just put someone on cruise control on a ventilator and walk away. You have to have someone there the entire time, monitoring vitals, monitoring the patient's status, and making changes and administering medications that they need. So it's important that we consider this when we come up with our break strategy. So what that looks like for me is that around 9 a.m. or a little earlier, I go into a room and I send the person who's in the room out for their break, and I am in that room for the time. And then generally we will finish our day when the surgeries are done, or if a surgery is going to go beyond 5 p.m., usually we can sign out or hand off the patient to another anesthesiologist. I want to bring up this issue of call. So a lot of you may hear about taking call in a variety of specialties. In anesthesiology, what I'll say is that the operating room has to be available 24 hours a day, 7 days a week, 365 days a year. And so as a result, you need anesthesiologists that are ready and available to be able to provide anesthesia in case there is any emergency surgery or surgeries that go in an unexpected realm or go unexpectedly longer or hit complications. So as a result, we have to take call. So for me, I have a little bit of a different type of call situation because I'm also a critical care anesthesiologist. So I spend my time on call actually in the ICU. But my colleagues that stay within the operating room, they will stay for overnight call typically. And on weekends, they will do 24 hours where they are staying in the hospital to be readily available for any surgeries that come through. Now, to learn a little bit about anesthesia, I want to go over different anesthetic techniques or types of anesthesia, just so that you have an idea of what are the types of anesthesia we can provide. And then we will try to apply this knowledge to some cases, some frequent cases that we see. The first and foremost type of anesthesia is general anesthesia. That is what most people expect when they see an anesthesiologist for surgery. They think that they are going to be completely asleep. That's what general anesthesia is, when someone is completely asleep and we take over for their airway in some ways or help or assist in their breathing at that point as well. So general anesthesia is the most common thing that people associate anesthesia with. There are certain types of procedures like laparoscopic procedures that are typically done under general anesthesia. Procedures that have a lot of blood loss or potential for complications are done under general anesthesia. But that being said, not all of those things have to be done under general. Two things that I like to go over in terms of general anesthesia is that this is an endotracheal tube. What you'll see is that it's literally a plastic tube with a balloon at the end and then something towards the end that helps us be able to control the inflation of that balloon or deflation of that balloon. So when someone is undergoing general anesthesia and we want to secure their airway and hook them up to the ventilator, then we would put a breathing tube in, also known as an endotracheal tube. The procedure of putting the breathing tube in is called intubation. And this is the same thing that we are actually doing for patients that have COVID that end up in the ICU and need to be hooked up to a ventilator, is that they actually need a breathing tube in order to hook them up to the ventilator. Now, the breathing tube goes into the trachea, which is the windpipe, which you can actually palpate when you feel your neck. It is not in the esophagus, which is behind your windpipe. So the esophagus is your food pipe. And we avoid putting it in the food pipe because that is not the place that it should go. Now, another device that we can use for general anesthesia is called a laryngeal mask airway. It does look like this top thing. It's like a little mask that actually goes into the mouth and sits on top of the windpipe. And what we can do with this is we can use the ventilator and help someone breathe, or we can have someone breathing on their own using this device. But one of the things that we find or see in anesthesia is that after someone is asleep, that their tongue can frequently flop backwards or get in the way, and that can stop or obstruct someone's ability to breathe. So this laryngeal mask airway, or LMA, is one of the devices we can use to assist with breathing. Just so that you guys are aware as well, the emergency room can use LMAs, ENTs can use LMAs, out in the field, people can also intubate. So these are shared procedures and shared types of airway devices that other specialties also can be trained in using, but we use very frequently in the operating room. Another kind of anesthesia is called monitored anesthesia care. Now, this is more like sedation, and sometimes some procedures are better off done without the patient completely asleep, because general anesthesia, especially in a sick patient, can be very dangerous. Sending someone off to sleep can really change their vital signs and can cause someone to even die or arrest. And so as a result, sometimes monitored anesthesia care is the better way to go, where we provide some medicines that help someone relax. We provide pain medicines as well, if this is a procedure that could be painful. And those are the things that we will do in monitored anesthesia care. These are typically procedures that that are not very painful that we'll do monitored anesthesia care for, or we will combine MAC, or monitored anesthesia care, with another type of thing, which is spinals or epidurals or regional blocks. As I had mentioned earlier, sometimes what we can do is actually place some numbing medicine around nerves, and that allows for that total extremity or whatever we're blocking to be totally numb. So a spinal or an epidural is actually a procedure where we place a needle in someone's back and either get into someone's intrathecal, that means the CSF, the place where the CSF sits, into that space, and we can put numbing medicine in there, or we place an epidural, so epi being outside of the dura. So if you've learned about the layers of the meninges, the dura is the outer layer, and we place it right outside of there. In terms of being able to place medicine there, so for a spinal, we'll go ahead and put a very small amount of numbing medicine into that CSF space, and it totally can numb up a patient from kind of the chest all the way down. And whereas an epidural is something where we can place a catheter all the way into that space, and then we can continue to place medicine in there. So that means that a spinal, once it wears off, we have no way to give more medicine. And an epidural is something where we can continue to give medicine and maintain their level of numbness. So we'll use epidurals for laboring women, for their C-section, same thing for spinals, or we can also use this technique for different lower extremities. So if you're getting a knee replacement or a hip replacement, we can do that under spinal, and that allows for us to combine that with things like monitored anesthesia care or MAC, so that a patient can be totally awake, getting their knee replaced, getting any kind of foot surgery, getting their hip replaced, sometimes even for some of our prostate procedures, or we say cystoscopies, when someone takes a camera and looks at the genitoureteral tract. Those are areas in which we can use this technique to numb them up and allow them to undergo a procedure. Now, another really important part of what we do in the operating room is monitoring. So monitoring specifically a patient's vital signs the entire time. So in anesthesia, we say that we need to always be monitoring our ASA standard monitors. We need to use our standard monitors. And the ASA is the American Society of Anesthesiologists. And they have put out a guideline, practice guideline, that for patients that undergo anesthesia, they need to have 5 components that are monitored. So that includes an EKG, it's 5 leads. EKG, that's that rhythm of the heart that we monitor. It includes a non-invasive blood pressure. So when someone puts a blood pressure cuff on to measure your blood pressure, we need to be able to keep an eye on that, because a lot of our anesthesia medicines can make someone's blood pressure dangerously low. We also will monitor pulse oximetry, which is your oxygenation of your blood. And it's also another thing that we have been seeing more and more understanding of because of the COVID pandemic. We also monitor temperature of the patient, because temperature is actually very important for both patients being able to stop their bleeding or be able to clot, as well as even for patients to wake up and metabolize, so break down the medicines that we give them. And finally, end tidal CO2. That means that at the end of your breath, so when you exhale CO2, and that's an important byproduct, that you're breaking stuff down in your body. It's also an important thing for us to be able to monitor if someone's ventilation or if they're able to breathe properly. Now, another way that we can monitor blood pressure is through something called an arterial line. And in order to place this, it's kind of like a peripheral IV or intravenous line, but instead of putting it in a vein, we put it into an artery. And arteries are the things that you can get a pulse from. We don't typically put it in the carotid, so that's not a place we would typically go. Typically, it's places like the radial artery. So if you feel for your pulse next to your thumb over here in the wrist, we can put a small catheter in there, or a small kind of plastic tube, and hook it up to a monitor to be able to see someone's blood pressure every single time their heart beats. And that will help us to make sure that we can give the right medicines to maintain someone's blood pressure. or if they have a weird electrical rhythm. So a common rhythm older patients have is atrial fibrillation. That means that the heart is not squeezing and at kind of a normal rate. Typically, if you feel for your own pulse, it's a regular rate, but patients with atrial fibrillation have a very irregular rate. So they will squeeze and then squeeze a couple times and then squeeze again. And so sometimes it can be very tough for that blood pressure cuff that you typically see to give us the blood pressure value because of how irregular the heart is beating. Additionally, sometimes patients can lose their blood pressure or have really low blood pressure very quickly because of our medicines or because if they're very sick. And a blood pressure cuff, usually if you remember ever getting your blood pressure checked, it takes some time for it to show up. So the time it takes to squeeze and then let go, that actually is a full probably a minute of time. And in that time, someone could actually lose their heartbeat completely. So those are the patients that we would consider putting an arterial line in. Additionally, we can also get labs from this line very easily. So it's another thing that we consider when we're placing these lines. Another thing that we will do something called a central line. So a central line is like a really, really big IV. So it is a long catheter, a long plastic catheter that will go in through some large vein. Typically the internal jugular vein is the one we place it in. And we do that under ultrasound. We get into the space and then we go ahead and put this catheter in. It's important for us because in anesthesia, we will sometimes provide some medicines that are very, very caustic or dangerous to veins. So if we give the medicine through a vein and the vein were to blow or the IV were to blow, which happens frequently, then it would be dangerous to the skin or to the soft tissue around where the IV is. In that instance, we would use a central line instead to give those types of medicines. And another really important component of anesthesia is the fact that we have to be very, very good with pharmacology. We really have to know what a lot of medications are, what they will do, the appropriate doses to give, and then how to prepare them. That's the other part. I love being an anesthesiologist because we really are kind of a jack of all trades. So a lot of doctors are not very comfortable with phlebotomy or getting blood for different types of tests and things like that. A lot of doctors are not really good at placing IVs because typically a lot of nurses will do that role. But as an anesthesiologist, I am able to get IVs in patients. I'm able to draw blood. I'm able to hook them up to intravenous lines and fluids. And I am also able to diagnose these patients, be able to determine, okay, this medication or that medication is appropriate, and pull up and draw up those medications and administer them myself. A lot of doctors don't get training in how to do those things because they rely on pharmacists to confirm that their medication choice is correct, that the dose is correct, and or nurses to be able to administer those kinds of medications. But in the operating room, there's only one to two people that are doing that role, and that's the anesthesiologist and or the CRNA or resident that they're working with. So this is a fun part of the job, is to be able to be comfortable with all of these things in order to care for patients. It also means that when I was called on an airplane to help with a patient with a medical emergency, that I was very comfortable with diagnosing, assessing, and treating that patient. So it's a lot of fun, but it also means that we have to be very vigilant about what we do because it's possible to do errors in our medication administration, and that's something that we like to obviously avoid because we care about patient safety. Okay, let's go over a couple of cases that we will typically see. I currently, in my job, have a home base of orthopedics, so I see this very frequently. So one of the things, a knee arthroplasty is a surgical procedure where you get a knee replacement. Some of our patients are typically older patients. It's typically because of wear and tear on joints. So it's very common to get a knee replacement. So I want you to take a moment and ask yourself, what type of anesthesia would we be able to provide for a knee replacement? I'll give you 2 seconds to kind of think about it. So for a knee arthroplasty, one of the things that a couple different ways of anesthesia we can provide are you can get a general anesthetic. So for pretty much any kind of surgical procedure, you can offer a general anesthetic. However, with general anesthesia, if someone has any lung disease, so COPD is one example, someone who's on a lot of oxygen, or if they have a pneumonia and they come to the operating room because they need another procedure, those are things in which we don't want to do general anesthesia because we have to take away their ability to breathe, and we might cause them to have something called atelectasis, or their lung is a little more collapsed and they're not able to take a deep breath. And it's also possible too that if someone comes into the operating room and they're very, very sick, that by inducing general anesthesia, we can make them more sick. So in patients that we want to avoid general anesthesia for, we can actually do a spinal anesthetic for this. And a lot of the time we actually do a spinal anesthetic for these patients because it means that they don't get any kind of manipulation of the mouth. They're totally numb from the waist down. They can get the procedure done. And then when we're all done with surgery, they can go ahead and start walking pretty quickly afterwards once it wears off. These patients, it's much nicer of an anesthetic to do a spinal anesthetic with monitored anesthesia care because of the fact that our patients will wake up much quicker. Under general anesthesia, many patients are quite sleepy after they wake up. So for this particular procedure, we could do a general anesthetic, we could do a spinal anesthetic with MAC, we could even do an epidural. I've done that for some of our sicker patients as well. Okay, another common procedure we will do are laparoscopic procedures. Younger patients oftentimes come in with appendicitis, and so we'll get called to provide anesthesia for patients that need a laparoscopic appendectomy. For this type of procedure, what do you think anesthetic we should do? So for anything laparoscopic, it is possible to do what we call neuraxial, which is spinal or epidural. However, because of laparoscopy requires that we insufflate, so we put a bunch of air into the abdomen to blow it up so that they can see with their equipment how to do the procedure and what they're going for. It's typically quite uncomfortable for patients to feel that insufflation. So because of that, for most laparoscopic cases, the vast majority of them will get a general anesthetic. The next type of case, I mentioned earlier that in cardiac surgery, we can do coronary artery bypass grafting or some kind of and valve replacements as well. So for this type of procedure, they're going to have an open chest. What do you think type of anesthesia we should provide? So for this one, I've kind of alluded to this. You can actually do this under epidural, but typically patients are not very comfortable with the idea of trying to breathe when they can't feel their chest. And so as a result, that plus the fact that we use a lot of blood thinning medicine during cardiac surgery, these patients receive a general anesthetic. I've also mentioned earlier that our cardiac anesthesiologists place a special kind of echo probe that goes in the esophagus, and most awake patients don't like that. And so as a result, a general anesthetic is usually the safest way to do coronary artery bypass grafting. That being said, if we did a transcatheter approach, so nowadays we've been able to do a valve replacement through the groin, so very minimally invasive type of valve replacement or cardiac procedure, then in those cases, they might actually be able to get monitored anesthesia care, but not for open heart surgery typically. Now, obstetrics, another area that we frequently go to. If someone is getting a cesarean section, how do you think we would do their anesthetic? I kind of gave this answer away earlier, but for obstetrics, we usually like when moms are awake. Typically, moms want to see the birth of their baby. They want to be able to do skin-to-skin time. They want to be able to breastfeed. And so as a result, we try to do either a spinal or an epidural for these patients. Cesarean sections can happen either after someone has been trying to give birth for a number of hours or is laboring for many hours and they decide that the baby won't descend or won't be able to be vaginally vaginally delivered. And so we can use the epidural that was placed for labor in the operating room to do a C-section. The other approach is that sometimes moms will come in for scheduled C-section. So if the baby is not head down and it won't flip, and there won't be a safe way to be able to get the baby out vaginally, then patients will come in for a scheduled C-section. And those patients usually get a spinal anesthetic because it's a one-time dose of medicine, lasts a few hours, and they're able to do surgery very well with that as well. Sometimes in emergencies, we do need to do a general anesthetic for obstetric patients. However, it can be more dangerous for obstetric patients because they have a baby there, and the baby in the belly can push on the stomach and cause the stomach contents to come back up and into the lungs, which we like to avoid. And finally, another area we go into is endoscopy. So many of you may have had family members or you yourself undergone endoscopy, which is taking a camera and looking in the esophagus or from below. So from the esophagus, it's called an EGD or esophagoduodenoscopy, or from below, it's a colonoscopy. So it's basically a camera that takes a look at the GI tract. So for this type of procedure, what do you think we would provide? So typically for this, we actually do a monitored anesthesia care, even though it sounds really crazy that putting a camera both from above in the esophagus or from below would be really uncomfortable. It's actually not as bad as you would think. And so as a result, a lot of these patients do really relatively well with just sedation and not general anesthesia. But of course, in any situation, there can be emergencies and we would do general anesthesia for those cases. For example, if a patient were to come in because they're bleeding from their esophagus or their stomach, and so as a result they're throwing up blood, those are patients that are pretty dangerous to just sedate, so we would then do a general anesthetic with an endotracheal tube. Okay, that was 45 minutes of everything I could think of to share about my specialty. I'm active on social media. I'd love to hear from you guys if you directly as you're going through your journey on my Instagram. And I also share about a lot of my day in the life on YouTube as well. I'm happy to answer any questions now.
Thank you so much for your presentation. We do have some questions. So the first question is, if you could change anything about the field, what would it be?
Ooh, that's a really good question. I think that it would be the public's understanding or perception about what we do in anesthesia. I think that there's a lot of misconceptions when I care for these patients that come in. I tell them about the fact that we'll intubate and that they'll be asleep for these things. And, you know, we make it look like anesthesia is a really easy thing. And while it is a very safe specialty right now, you know, undergoing anesthesia is much safer now than even just 4 decades ago because of new technology like the pulse ox and being able to monitor end-tidal CO2. Even though it's really safe, it does take a lot of specialized training and experience to be able to care for a lot of the patients that we care for, or sometimes even healthy patients, there can be complications from surgery that an anesthesiologist needs to be well equipped to be able to safely take care of that patient. So I think that it's really our education of the public of what we do is one thing that I would really like to change about my field.
How do you handle patients that may be nervous before a surgery?
Such a good question. So there's a lot of different ways that I like to address this. There's 2 main kind of directions one can take. So one is that just sitting down, I personally love to just sit down with my patients and ask, you know, what is it about this particular procedure that scares you? What is it about undergoing this or your diagnosis or whatever else that's going on that is scary to that patient? And I like to be able to talk to them. I like to be able to then also use, you know, conversation as a way to help relax these patients, because I'll talk about things like I'll ask about the patient's family, if they have kids, if they have pets, you know, evoke positive memories and evoke positive feelings and so that they're not focused on what's to come with their procedure. Other things that we can do is we do have a lot of anxiolytics, so medicines that can help take anxiety away that we can administer through the IV, and we can do that as well. So it's all a balance kind of about addressing and assessing whether the patient will do better because they need a little bit of that anxiety medicine that we can give. Some of these patients are actually on some of that medication at home already. So if that's the case, then I will just administer it through the IV as well. But typically I like to talk to my patients and really understand where they're coming from so I can help alleviate those fears and anxiety.
Why did you exactly choose to be an anesthesiologist?
I spoke for about 20 minutes on my YouTube channel about becoming an anesthesiologist, but the short story or short version of that is that during medical school and even earlier than medical school, I was really looking at all the different specialties to find the place that was a good fit for me. So throughout, I would say when you become a medical student in any country, you get to be able to explore different specialties, and each specialty has its pros and cons. And what I personally found was that I really loved the environment of the operating room. So that was one place I wanted to be. A lot of people like just the regular hospital environment, or they like the clinic. So when you go visit your own PCP or your own doctor, that's in a clinic setting or office setting. I did not like that. And so I knew that I didn't really want to be in those types of settings. So I decided, I really liked the operating room setting. And then I had to make the decision, well, when you're in the operating room, there's really only two directions you can go. You can be a surgeon or you can be the anesthesiologist. And what I found was that surgery was not the right fit for me. I didn't feel like that culture was aligned with what I wanted to do in my life. I didn't feel like it was the individuals that were within the surgical culture didn't really perpetuate. They weren't the people that I felt like I got along with. And so then I checked out anesthesia and I found that it really offered a lot of everything that I wanted to be able to do. So one component of it is there is flexibility within my field. I can hand off a patient to someone else and leave at 5 p.m., or I could stay and see it through, see the case all the way through. So having kind of a shift work type of schedule makes it a lot nicer of a kind of work-life balance, and being able to kind of leave work at work. That's the other big thing, is that my patients in anesthesia typically don't need to call me for medication refills. In fact, I don't do medication refills. So as a result, those types of after hours things that cause doctors to burn out are things that I don't encounter. But I didn't like the fact that I only got a really short period of time with patients. And so that's why I also did the critical care fellowship, so I can have longer term relationships and care for these patients besides in one surgical time. So long story short, I explored all the different specialties and I found that anesthesiology was the right mix of a lifestyle, of the clinical work that I liked in an environment I liked in the operating room, and with people that are very like-minded to me. So they will often tell people who are looking to figure out what specialty they like to find people that are like you. Your personalities are similar. I'd say most anesthesiologists are very kind of cool, calm, collected, especially under pressure, because this is what we train to be good at, but also are very meticulous and very thoughtful about a lot of things. We are planners. We like to anticipate things. We have to be able to anticipate what's the worst case scenario so we can be prepared for it.
What tips would you give for being productive and coping with stress, as med school is hard and stressful?
Oh, such a good question. So I think the most important thing when having, faced with stressful situations and the stress of medical school really is knowing when to take a break. That's really one big area that I think a lot of people don't realize. They end up, instead of like taking a dedicated break, they end up just doing this a lot. They're on their phone. I'm going to scroll through Instagram when they're in the middle of a study session. And doing that is really inefficient. So learning how to be efficient with your time. So knowing like, I'm going to sit down for X amount of time to study and I'm going to get X thing done, or acknowledge that it may not be possible that day to get X thing done. Those are the things that I think are really important, but really taking real breaks, not like fake breaks. I think fake breaks are what really get people, because you see people will study for 12 hours a day, but in reality, they spent 10 of those hours on Instagram or Facebook or TikTok, and they're not actually focused on the task at hand. So I really actually never studied as much as a lot of other people say they have, because I know that if I start kind of wandering, if I start thinking about something else, if I'm planning my dinner, then I'm not actually studying right then. So I have to take some time away from it, and then I can refocus my attention. The other thing about stress is that it's important to recognize where the stress is coming from, because if you can recognize, okay, I'm stressed right now because of the upcoming exam. So how do I address that? I'm stressed right now because of issues that are going on with my relationship. So how do I address that? It's really important to identify where the stress is coming from, take those breaks, and then be able to also recognize that you may need to call upon other people to understand or realize or come up with other ways to address what's going on in your life. Because at the end of the day, you think you know yourself, but in reality, sometimes you just need to call your parents or call your best friend and be like, I'm feeling so stressed out. Can I talk about it? Can I just figure this out with you? And be able to kind of go from there.
After administering general anesthesia or any other form of anesthesia, how do you determine that a patient can be sent home?
Oh, that's such a good question. So patients have to meet certain criteria to be discharged from kind of the recovery areas. So what I didn't really talk about in this talk was that after anesthesia, all patients go to a recovery unit or post-anesthesia care unit, also called the PACU, PACU. And in the PACU, the nurses are doing an assessment to make sure the patient is awake enough, that their pain is controlled, that their nausea and vomiting is under control, that any other things like we have to wait for some patients to be able to void or to urinate after surgery, because some of our medicines can cause retention or stop you from being able to urinate properly. And so those are all criteria that we have nurses that are specialized in looking for those things to assess. And when the nurse feels like, okay, this patient has met these criteria, they're not in pain, they're not nauseous, they're able to take some medications, they have urinated and have voided, then they will call upon either one of our anesthesia residents, or we have some nurse practitioners that we work with, and that person will come and assess the patient and decide, okay, is this patient safe to leave the recovery area? When patients leave our recovery area, then it's up to the surgeon, the surgical team, to be able to assess if the patient is finally safe to go home, because the surgeon is the one that will be doing the medication prescription. So if someone needs pain medicine to go home, that's the surgeon writing that. The surgeon is the one that will provide instructions for how to care for if they have a dressing or any kind of covering over whatever surgical site they have, and then to be able to provide a follow-up in the office. And so those are the kind of the two components about making sure someone is safe to go home.
So anesthesiology is a critical branch requiring one to make decisions in a matter of minutes, including life-saving decisions. How does one deal with the anxiety associated with it?
That's a great question too. I definitely, I can't say that I'm not nervous when I am encountering a really, really sick patient, but that's why we train for these types of things. So in my training, I have encountered patients that have had really bad traumas. So that means like motorcycle accidents, motor vehicle accidents. We've had patients that have, come to us after a plane crash and they're very, very sick. And it's those moments in which we have to make decisions that influence how they will do. And as a result of that, I think what's important to recognize is that every anesthesiologist has undergone really, really extensive training in order to recognize which things are going to kill a patient and fix them and be able to know how to fix those things. And a lot of the time, it really is about experience. So if you keep getting exposed to sick patients that are in life or death situations, you will become more comfortable with, okay, delegation of tasks. That's the biggest thing thing I would say is that you, as the anesthesiologist, anytime I am in a situation where I need to kind of lead a code or someone who's, had a cardiac arrest, the most important thing in my mind is being able to delegate, because one person cannot do everything. So calling for help, if you yourself are not able to focus on delegation or leading the team, then, assigning that role to someone else can be really important. So when I led a code recently, the things that I recognized was that, I had to know who was in the room. So I called upon another surgeon to come in and get a central line for me. I called on the nurses to change the medications to a certain thing. We called the pharmacist to come in so we can administer specialized medications. I asked people to help with CPR and to have a setup for that. And I called for other help to come in. So the biggest thing to recognize, I think, is realizing that there's always people that can help you as well, and knowing when you need to call for help, and then also being confident that you can diagnose what's going on and move on that.
So the next question we have is in regards to the appendicitis case that you presented. So they are asking, if the abdomen is inflated, does it not have any effect on the lungs at all?
Oh, that's such a good question. Yes, with insufflation, we frequently see changes in our ventilator settings. So because the insufflation pushes up on the diaphragm, usually the space that the lungs are able to occupy is actually smaller. But for most people, most healthy people don't need all of that lung in order to still be able to oxygenate the blood. So as a result, we can still deal with having kind of less lung to be able to get oxygen exchange and CO2 out, but we definitely have to make adjustments on the ventilator when someone is insufflated.
So the last question we have is it okay to go to a community college, then transfer to university if I want to become an anesthesiologist?
Absolutely. I love this question because I think it's so important that people think about what's best for them and also think about finances, because I think one of the things that no one really tells you guys about as you go into medicine, especially in the US, is that it's really expensive. And even though you get your salary is good at the end of it, it takes a lot of time to pay off all of those loans. And at the end of the day, you need to be able to go to places that are going to fit where you are in life right now. So if right now it's best for you to save money, stay at home, go to a community college, get a 4.0 and transfer to a state school, that's totally fine too. I will just mention that by not being in the same school for 4 years, some of the leadership opportunities that are available may not be there when you transfer, and it may be hard to adjust. When I transferred to the University of Michigan, my GPA plummeted because I was not used to having a huge school. I was not used to the engineering classes. And honestly, I didn't really have a lot of friends that were available yet because I didn't make new friends yet. And so those are some of the things I think you need to consider, because it's important when you apply to medical school that you have a really good GPA and you also have those extracurricular activities that show that you're well-rounded, that you can be a leader, that you care about community service and giving back. So you just have to know what's best for you and also acknowledge and prepare and plan for some of the things that can happen as a result.
Thank you, Dr. Amanda, for joining us today and teaching us about this field. It was an amazing presentation. For those watching this, the link to the quiz will be posted on our link tree found in the Instagram bio and has also been posted in the chat box. Our Instagram ID is way_organization, so please make sure to have a look at that. And within this week, we'll also be emailing you your certificates. Thank you once again.
Bye, guys. Thanks.